Okay, it's 2 after 2, so I propose we just get started, and if folks join, we'll catch them up. And there's also 2 more of these information sessions scheduled, so there's more opportunity to circle back. Can we start? First of all, I just want to welcome everyone. Thank you for joining. Can we start by doing introductions of who's in the room? I'm happy to start. My name's Eric McNair Scott. I am Director of Community and Clinical Linkages for Southwest Washington Accountable Community of Health. And maybe I'll just call on folks as I see your name. Jody, would you mind introducing yourself?
Sure, absolutely. So I'm Jody Friedenfeld, and I am the Volunteer and Engagement Supervisor for the Bridgeview Resource Center.
Okay, thanks, Jody. Rebecca?
Hi, everybody. Here, I can turn my video on. You can see half my face. I'm the Executive Director of the Free Clinic of Southwest Washington.
Thanks, Rebecca. Yvonne?
Good afternoon, Yvonne Fitterer. I'm the Compliance Manager for Grants with Columbia River Mental Health Services.
Okay. Excellent. Well, thank you all so much for joining. I first want to check in and make sure that folks have had a chance to access the RFP on the SWACH website and find out if there are any challenges accessing it. I just looked at the website today and I was challenged finding it. So I know I sent some folks the link, but I wanted to hear back whether folks have been able to look at that in detail. Yes, I'm seeing thumbs up from Rebecca, nodding from Jody. Yvonne, were you?
I had the link to it, but when I did go to the website, I wasn't sure how to get to it, but I did have the link from Sarah Brown. She forwarded it to me with, she's with Columbia River. So I was able to access it that way.
Okay, yes. And so I know I just we'll update the website to make sure that it is front and center when people come on as we move forward. I want to make sure there's plenty of times for questions. So I do have a little bit of a slide deck that just gives an overview and then kind of runs through the RFP questions. What I'd really like to encourage, we're a small group, and I want to encourage you to interrupt me at will. And really, let's make this as informal as we can. So as questions occur to you, feel free to stop and we can discuss it. I can always capture the questions and we can make sure to circle back at a different time. But I'll just launch in and say that the foundational approach, which I think we're all familiar with, but it's worth restating, is an approach to whole person care, which looks at physical health, behavioral health, and social needs as a holistic approach. And that's the underlying approach that the HealthConnect Hub and SWACH takes for community-based care coordination as an approach to break down the fragmentation and siloing of systems. This slide is, again, something I think we're familiar with, that we have the dubious reputation internationally of spending the most and having some of the worst outcomes considering how much we spend. And SWACH, as an accountable community of health, has been tasked with working with partners to support systems change for more effective care. And we believe, and we've seen this working out, that the community-based workforce and community-based care coordination is a cornerstone of better approaches to whole person care, and a good place to invest our funding to support whole person care. And so we continue to support that with our partners. This slide is a little more busy and I won't spend a lot of time. I'll share this deck with folks afterwards. But I wanted to highlight that the HealthConnect Hub is an infrastructure for community-based care coordination programs that connects and coordinates and collaborates across programs that are integrated with the HealthConnect Hub. And down the right side are the current care programs that are integrated by the HealthConnect Hub. And by this, we mean that there are a workforce of community-based workers that could be CHWs or peers or community-based social workers or community-based paramedics, community paramedics that are providing community-based care coordination through different models, but also all using a common community health record that is supported by HealthConnect's data platform and infrastructure. And that common community health record means that we can support centering the community member. If there's a community member who engages with a community-based care coordination program through the top program on the right there, the CareConnect Washington program that supports COVID response, they can maybe get immediate support to isolate and quarantine at home, but then they could be referred to, say, the HealthConnect Pathways program for longer-term care coordination. The community health record, which supported their engagement with CareConnect, can transfer over to that other program, and that the next community-based worker can build on the existing community health record. So there's not that continual reassessment, re-traumatizing, and also there's a collaborative approach to building on a common community health record. We have these various programs currently that are integrated, and the one that this RFP refers to is really the HealthConnect Pathways program, which is, I think, our foundational longer-term community-based care coordination program, and happy to talk more about that. The basic approach with HealthConnect Hub infrastructure around these community care programs is to have a hub or a common entry point for referrals. So the vision is to get to a place where there's a referral network, whether it's hospitals, whether it's individual referrals, it's clinics, it's community-based organizations, but they could refer to the HealthConnect Hub. And then the hub, based on the network of partners and agencies that are integrated with the HealthConnect Hub, can direct the referral to the appropriate agency and care program. So it's really supporting a no wrong door approach. Referrals come to the hub. The common consideration across all these programs is that they are community-based programs, which is not to say that the clinical centering, having clinical partners is absolutely essential, but this model really supports a centering of community support, meaning community-based workers meeting people where they are, both literally and figuratively, in community, as opposed to a model which requires folks to come to you. So community-based workers might, again, be community health workers, peers, community paramedics, or community-based social workers. But the commonality here is that we're working across whole person care, physical health, behavioral health, and social needs. And folks are coming alongside people in need to help create a care plan and connect the resources. And that is my 5-minute overview of the HealthConnect Hub. And I'm happy to go more into detail around any of that. So I'm going to pause here before we get into the actual RFP to see if there are any specific questions around either the HealthConnect Hub infrastructure as a whole or the specific HealthConnect Pathways program. Okay. So if I can just get a sense from you all, was that the information, the overview that I gave, was that familiar, or was it mostly new information, or somewhere in between?
I'm new to housing. This is all new to me, so I'm just soaking it all in. I come from compliance on the medical side, so I'm learning about grants in the housing. So like I said, taking a lot of notes, and so a lot of it is new to me.
Right. Well, I'm extending the offer at any point that, you know, whether it's here or in a follow-up, if there's more questions, we're really, you know, the totally open to having continued conversation to help clarify, or if there are any questions.
Yeah, I was already familiar with the Pathways program prior to this, so it was nice to have a recap, but I have a general working understanding of it.
Yeah, same for me. Eric, you and I had talked. It's been several months though, so the recap has been helpful for sure.
Great. Well, I'll take a moment and just say a little bit more about the pathways in particular, because this is what the RFP is. When we look at the various programs here that are connected, this RFP is for the HealthConnect Pathways program. We do have partners where, many partners actually, where they might have community-based workers or community health workers who are trained in more than one program, which is great. It really supports the breakdown of that fragmentation approach. So we might have partners with CareConnect Washington, community health workers who are also trained in pathways, who are providing support to people who have COVID for a 14-day period to quarantine and isolate, and then supporting people ongoing with longer-term whole person care supports through pathways. But in the case of this RFP, we're really looking at HealthConnect Pathways. So I'll take just one moment to, again, very high level break down Pathways. Pathways is based on an evidence-based model that came out of Ohio and is now a national model that was developed with community health workers directly in the center of the model. And Pathways takes an approach that that follows essentially 3 steps. There's an engagement piece, community health workers being trusted members of the community, have an opportunity to engage folks, meeting them where they are, where we've seen a much higher level of engagement than perhaps, you know, some other care coordination programs, because they're coming through the door, or they're meeting them in the community, or they share a common lived experience, common culture, common language. So we're seeing higher engagement. Then once there's engagement, there's an opportunity to perform an initial assessment. And that initial assessment identifies risk areas for the community member that Yvonne might have to do with housing, but it could also do with food insecurity, transportation. It could, you know, across the board, all the social needs, but also whether there are risks involved with physical health. Do they have a primary care provider? Do they have health insurance? Behavioral health, are they do they have a substance use disorder condition? Do they need access to mental health supports? So that initial assessment creates a map of risks that the community health worker then works with the community member to develop a care plan around. Pathways is a really innovative model, oftentimes considered a tool for community-based care coordination, because it does map out what to do next. Once those risks are identified, let's take housing. There are steps that are mapped out that the community health worker can support a community member to achieve. And then there is a successful outcome as those steps. And so for housing, a successful outcome is defined as 30 days in stable housing, and that's considered a successful outcome. And for every risk identified, there are steps that the community health worker should support a community member to take, and the identification of what a successful outcome looks like. So what we hear back from folks is Oftentimes, folks oftentimes have to get high levels of education, bachelor's or master's degrees in order to be able to navigate the systems. And what this tool provides is a clear map so that that you don't need a master's level in order to be able to come alongside and really support people. And it also really allows the other essential valuable piece here, which is lived experience, being a trusted community member, to come to the forefront so that folks who have that lived experience and are trusted also have the map to support people to achieve successful outcomes. The last part that I'll just call out here is that being an outcome-based model, there's also a tie-in with outcome-based payments. So if we can say that here are the risks and here are the outcomes, there's also the opportunity to incentivize those outcomes and really shift away from a fee-for-service model or a time-based model towards a identification of what outcomes are, attaching payments to those outcomes, which not only changes the funding landscape, but also allows us to capture outcomes and report out back to the community around what are folks able to access, what are folks able to successfully complete in terms of outcomes, what are the needs and opportunities in our community more broadly. So there's a lot more, of course, to talk about, but I think we want to dive into the RFP. Any questions about pathways before we do? Okay. So what we see this opportunity right now with the RFP is to expand the partnerships that we currently have for HealthConnect pathways. The applications, there's a pretty quick turnaround for an application where the applications are due on March 1st. They can be written or submitted, Word, PowerPoint, PDF. Also, there's no length requirement, but really just what is needed to answer the 7 sections of the application materials, and we'll review those. Also, if there's any, if there's interest or if there's an applicant who feels that their application would be stronger using other than a written format, we can also work with folks around a meeting and having a verbal application or a video application as well. So if there's interest in that, please do let me know. The RFP has said 7 sections, but I think there's actually 6 sections. One is just the basic profile of organizational information, what your organization's mission statement and vision values are, and 501c3 status, or if you're not a 501c3, information about your fiscal sponsor. We're going to look into each of these a little bit more. So I'm going to just jump to the next slide. And I'm going to just pause. So are there any requirements? Okay, so I'm going to move to the next one. So in terms of the questions for the RFP, the first section is around alignment with HealthConnect. And there's 2 questions in this. The first is, why are community-based workers or community health workers, peers, etc., so central or important to the HealthConnect partnership and the work of whole person care? And so this is really an opportunity for applicants to share their understanding of how moving forward as the HealthConnect partner does center the community-based workforce and why that's important to this work. The second question, how would your organization support and supervise a community-based workforce team? Is your organization prepared to supervise this team? Recognizes that a community-based workforce team does operate, is a unique, well, I don't know if it's unique, but it has its own characteristics. you folks are working out in community, when you have a group of folks who have diverse cultural lived experience background, it's important that an organization is prepared to offer support so that folks succeed and retain in the organization, for cultural diversity, for the lived experience diversity. And so this question really asks applicants to reflect on, is there consideration about how best your organization would support this workforce? And what does that look like? Any questions about the alignment with HealthConnect section? Okay. The next section is around priority populations. This work focuses on promoting equity, and then we provide a definition of equity, which is creating an environment free of exploitation and oppression, in which structures support people's ability to participate in social, political, and economic institutions based on their capacity. We see this opportunity as the continuing evolution, I think, of our region around community-based care coordination to center equity and create access and engagement opportunities to systematically marginalized or historically marginalized groups. So one of the questions, the first question is, how has your organization created equity with systematically marginalized or historically oppressed racial and ethnic groups? And another is, if your organization has limited experience with equity work, how will you include it in your project? So what would your approach do? Everyone's on, there is no arrival on the equity journey. Everyone's at different spots. So it's really a kind of a question of, where is your organization in the equity work? And what are the plans and thinking of your organization, your strategic plans to continue developing your equity approach, and how does that align with this application and the HealthConnect community-based workforce? Whoops. Connected to this question is around priority populations, is an identification of what the main priority populations for HealthConnect is. And there are 5 that have been identified. The priority populations were identified through independent evaluator review of data, the community needs assessments that were done in Klickitat and Skamania and Clark, as well as direct feedback from community-based workers and agencies. The top bullet point there is systematically marginalized and or historically oppressed racial and ethnic groups. Another priority group is individuals experiencing houselessness and housing instability. Another one is individuals with behavioral health conditions, particularly substance use disorder. The next is individuals with complex and or intersecting physical and behavioral health conditions. And another one is rural equity, recognizing that individuals with support needs living in rural areas, there's often equity issues in terms of access and engagement as well. So how do we support that geographic equity? So the main question here is, what experience does your organization have working with these following populations? And really just to highlight how your organization, how as an applicant, is positioned to support or represent the various priority populations through this work. And I will say that they're all important and obviously intersecting priority populations. Primary preference will be going to applicants who can demonstrate a readiness or a position to represent and support diverse populations. So that first bullet point of priority populations being systematically marginalized and or historically oppressed racial and ethnic groups is really a primary focus for this RFP. We see this as an RFP to, again, increase and advance equity in our region. And we see that priority population, of course, as intersecting with the other. So I'll pause here. Are there any questions about the priority populations or centering equity for this RFP? Okay. The next section is another thing I know we're all familiar with, but we're calling out social determinants of health related to equity. And there's a question that asks applicants to describe what is the importance of social determinants of health in addressing issues of inequality and oppression. How will your HealthConnect Hub partnership address racism, discrimination, and other forms of institutional inequities? And which groups are the most impacted by this project and or partnership? How will you bring their community voice and leadership to your project? I do want to recognize that these are big questions. They're big questions, and you know, you could write your PhD thesis on probably any one of them. So again, it's really about applicants being able to speak to how their agency is positioned to consider these questions in the work forward, and how the answers to these questions inform your thinking about how you would move forward as a HealthConnect integrated partner. Any questions about this slide?
I think I just maybe have just sort of some general questions, which is
Sure.
The HealthConnect Hub partnership, you know, because it's an existing model, I guess I'm having a hard time understanding how our responses to this, you know, how we make this project sort of our own when I'm sort of understanding it as we're just sort of being plugged into an existing model. Does that make sense?
Absolutely. Yeah, and that's a great question. So that is a great question, and I'll take a stab at an answer. I'm thinking back to a presentation by a housing agency that I listened to not long ago. And they talked about how the Pathways model is a tool for them to realize their own aims and strategies as an organization. That's really how I see it as well. The HealthConnect, the Healthcare Authority of Washington also has recognized that Pathways, it's its own model, but it's also an enhancement for agencies around how they do current work, which, by the way, is one of the reasons why we can offer both an FTE contract and an outcome-based payment contract and not have it be duplicative, because it's seen as an enhancement and not duplicating. So what I mean by that is, if you're an agency that is a housing agency, and you have aims and goals around housing agency, how does Pathways, by taking a whole person care approach, help you as an agency better meet your housing aims and strategies while supporting somebody beyond their housing needs, you know, physical health and behavioral health and other social needs? What we've seen is that we have agencies from various different sectors, and if the HealthConnect Hub is referred into, someone is referred into HealthConnect Hub who it seems clear that one of their primary needs is housing. Then clearly a connection to a housing agency pathways person makes a lot of sense. If it seems clear that their primary needs might be behavioral health, then having a behavioral health pathways CHW might make a lot of sense, because there's that intersection with what the agency's missions and goals are. So it's again, if somebody has complex chronic conditions, it might make sense to be connected to a clinic or a physical health clinic. And of course, nobody's just those things. But one of the opportunities here, having this network of partners, is to be able to have, it's kind of like the Venn diagram. It's there's a kind of a common core which Pathways represents, which is that we're going to work alongside people with community-based workers, and we're going to look at whole person care. But while we're doing that, there are going to be some community-based workers who speak two keys, and they work with this organization, and it really makes sense for the two keys community member to be connected to them. Or there might be community-based workers who are at a clinic who have complex, out of control chronic conditions, and it makes sense for the referral to go to them. So it is a model, but it's not. It's really it's a tool that agencies can use within their own mission and values to enhance the work that they're doing as well. Did I answer the question, or did I go off track?
No, that was helpful for me. Yeah.
Okay. Okay. Any other questions? We'll go to the next one. The next section is around meaningful impact. And this asks applicants to think about how will this partnership address a community need? So, you know, what community needs do you see as an applicant, and how does this partnership and moving forward address that community need? And then how will this partnership improve the connection of care and services, the care across organizations, and community conditions and environments? Any questions around meaningful impact? The last piece here is sustainability. So SWACH and HealthConnect, we actively work to develop and strengthen funding partnerships to sustain the work of community-based care coordination. Community-based care coordination is it's a model that's been around forever, but it hasn't been valued forever. And community health workers have been around forever, but they've not been valued or centered. And so as we do this work moving forward, we see our role as, sorry, the mailman cometh. We see our role as one, working with partners in order to really test the concepts, gather data, looking at the outcomes, establishing proof of concept. And we've really done that so far, and we'll continue to do that. Then to help amplify what we see as both the successes and the challenges of the model, share it with stakeholders at all levels, look at, you know, ROI, return on investment, and cost savings, and really make the argument as we continue to build our partnerships and see the outcomes for sustainability at all levels. We had, from the beginning of this, we didn't see this as a single agency like the Healthcare Authority or the MCOs being the main sustainers of this program, but we really saw that this kind of work has so much intersectional impact that there would be stakeholders across sectors that to whom we need to demonstrate the impact and then support their investment in this to sustain it. So we continue to do work around that. And the question here is, how will your agency support this work to sustain and continue beyond the next 2 years of funding, including bringing in additional support and funding? So really, we see partnerships not only around delivery of the work, but sustaining the work. And then the next question is, how will your agency champion and support HealthConnect's sustainability strategy? Any questions about that? Yeah.
Yeah, so what happens at the end of the 2-year funding? Like, would our organization still be a part of the program, or, you know, are we like indefinitely a part of the program?
Yeah, it's a good question. So if I'll give you the overall context with the Healthcare Authority and the Medicaid Transformation Project that started the Accountable Communities of Health overall. That Medicaid Transformation Project, when it first started in 2016 or 2017, was a 5-year Medicaid transformation process. There was $1.5 billion that the state had, or $1.2 billion, to support systems change. And it was 5 years. So as we started working with community-based care coordination, from the beginning, we were planning around how does this sustain beyond those 5 years? There's a lot of work, a lot of investment, a lot of workforce development and partnerships that doesn't just end after 5 years. It has been a continuing process of momentum and sustainability to support a foundation that does sustain. So the 5 years ended December 31st, 2021. We are now expanding. So as you can see, we have the work around sustaining has put us in a secure enough position that the board approved funding for a 2-year contract moving forward. We continue to work with the Healthcare Authority, with Department of Health, with other partners to that more and more are seeing across the state the value of community-based care coordination and writing that into their funding opportunities. So HealthConnect Hub becomes a vehicle through which funding can go upstream to community partners such as applicants for this. So we don't have, right now, we are secure in a 2-year funding opportunity to expand partnerships, and we have confidence, but we know that it's going to take continued work to build on the infrastructure both regionally and with our partnerships with government agencies to continue bringing in funding. What that might look like looks really different. I'll give you some examples of the braided funding that we've already reached. So, we have a partnership with Department of Health to support response to COVID, and the program there is called CareConnect Washington. So that program has funding for community health workers to come alongside people who are COVID positive and support them for 10 to 14 days while they are in isolation and quarantine. That funding is a different source than the funding for this grant, but that funding provides FTE for community health workers who could and do get cross-trained in pathways and then have access to the outcome-based payments to which are enhancements of that work. So I'm giving you that as an example because it's a current example of some of the braided funding approaches that HealthConnect uses to support sustaining multiple different programs, but then cross-training with pathways as a ongoing community-based care coordination program. So as we bring in funding for through DOH for CareConnect, that opportunity becomes available to our partners to get trained through CareConnect while continue doing pathways. as we recently received funding from HRSA for COVID engagement and education for diverse populations, and that was funding for community health workers. Again, FTE for community health workers. So that funding comes alongside, helps with FTE, and then those same community health workers could be trained in pathways and receive outcome-based payments as well. So you see, this is the braided funding approach that we take around sustainability, continuing to work with our partnerships with government agencies to reinforce the value of community hub infrastructure and community health workers. But we have no guarantees. And that's pretty much been how it's been from the beginning. I will say that we are in a stronger position, much stronger now than we were at the beginning. And that at the state level, community-based care coordination is being centered by the healthcare authority in their plans for moving forward with a 5-year renewal of the Medicaid transformation project.
Understood. Thank you.
So this is the last slide in the presentation. It's a little bit of an overview again of where we've come from and where we're at today. So HealthConnect started less than 3 years ago, 2019 in March. The first program, which was Pathways, was launched with 4 partners. Since then, HealthConnect, through multiple programs, has trained over 100 community-based workers to use a community health record and use various programs or models that are supported by HealthConnect. The community health records themselves, which represent each community member who is integrated in the system, the platform now holds over 13,000 community health records across multiple models. Really what that means is we're building, if we have this pool of community health records, it helps support what's been called, I don't know if you've heard this before, care traffic control. Care traffic control being the idea of managing, there's so many different care coordination programs. I know when I was in direct service, a lot of the folks that I worked with might have multiple care managers. They didn't know that one another existed, and oftentimes the community member themselves didn't know who was doing what. And care traffic control is the idea and opportunity of a central coordinating hub to, if there are multiple care programs that support a given individual, identifying that and supporting coordination across programs and care teams. So having a lot of community health records allows us to see when there's duplication, when there's somebody who was maybe a Health Homes community member being supported by Health Homes who now has been engaged through a community paramedicine program, and being able to connect back to a Health Home care coordinator or a Pathways care coordinator to support that continuity of care. A key piece here that obviously we've talked about quite a bit is having culturally appropriate response and engagement, really centering that the community-based workforce and the agencies that support them do center equity and support diverse population representation in their staffing and their work with community health workers. We talked a little bit about community investment finance and sustainability just now as we talked about braided funding. And then a key piece is also community engagement and power building. So a key piece that I haven't spoken about is that for the 100+ community-based workers and our current network agencies, we see the data platform infrastructure as foundational, but equally foundational is the opportunity to bring people together for shared learning and training, recognizing one another as resources, having continuous workforce development, and HealthConnect supports that through community cohorts, multiple community cohorts that come together on at least a monthly basis, multiple training opportunities as well, so that the community workforce continues to develop and become a more integrated like ecosystem of care that recognizes one another as interdependent. So with that, I'll conclude, and we can just open it up for a discussion. But that's basically the overview of the RFP questions and the context within HealthConnect. And I'll stop there and see if there's questions or comments. I was either pretty thorough or I was just horribly off the mark. It's going to be one or the other.
This was great information. Thank you.
Okay, great. Yeah.
I don't think I have any other questions at this time. They might come up, but I think I've got a better handle on it now. I was just mostly confused kind of about, you know, how we're supposed to kind of write this in a way that isn't just repeating what we know the program to be.
Yeah, no, thanks. I'm part of it is just demonstrating that you do understand what the program is, but then really and how that aligns with your approach, your agency's approach, and I think that's a really important piece of it. Yeah. Did this overview help answer that question, or is that question still lingering?
No, that makes sense. I think just kind of framing it in that way, which is talking about the program within how it would function within our agency, you know, what we're currently doing around social determinants of health and equity and those kinds of things. And essentially just kind of putting our perspective, our lens on what this program is.
Okay, well, then I will say thank you. Thank you everyone for joining. We'll give you back 11 minutes of your time, and really it's a open door. So if there are follow-up questions, feel free to reach out directly to me, and I'll be happy to follow up with you and help further clarify or discuss any questions you might have.
Thank you.
Okay, thank you very much.
Thank you.